please go ahead and click on that and do your pre-test. Click on it and all right. So thank you guys for participating. Dr. Bukal, over to you. I know that we have a message from Dr. Onanuju and a prayer, but we hand over to you to do the introductions before we get into that. Thank you so much.
All right, good evening, everyone. We'll have a prayer now by Dr. Arlene Henry Dawkins, one of our executive board members of the Caribbean College of Family Physicians, the Jamaica chapter.
Good evening, everyone. Let us pray and invite the presence of Almighty God, Jesus Christ, and the Holy Spirit in our midst. Most righteous, holy, and loving God, we praise and thank you for your faithfulness and love for us. We come humbly asking for your wonderful blessings as we meet once again virtually for today's seminar by the Caribbean College of Family Physicians. We ask for your wisdom and guidance during this seminar, and that you will empower all the presenters to impart their expertise and knowledge of the various topics with clarity and passion. Grant that we will listen with compassion and eagerness to absorb all the valuable information shared on optimizing adolescent health so that we will capably use the knowledge gained to enhance the lives of the vulnerable and valued adolescents trusted in our care. Bless richly the moderator, the sponsors, the administrator, and the audiovisual personnel as they execute their various roles this evening to ensure the seamless flow of all the proceedings. May we achieve an excellent and successful seminar in the end that will ensure we are empowered with the best management skills for persons in our care as health professionals. We ask all these things through your precious Son, our Lord Jesus Christ, in unity with the Holy Spirit. Amen.
Amen. And now we welcome Dr. Seni Ananuju, our president and leader. She will offer the greetings.
Good evening, everyone. Our specially invited guests, Doctors Julia Rowe Porter, Christopher Daley, and Leo Walker, moderator Dr. Keon Bukal, esteemed colleagues, friends, ladies and gentlemen. A pleasant good evening to you all. It is indeed my pleasure and honor on behalf of the Caribbean College of Family Physicians, Jamaican chapter, to bring you greetings and welcome you to this evening's webinar on adolescent health and STI, part 2. This evening's webinar is the college first webinar for 2024. At this time, let us observe a moment of silence for those who have departed. This evening we pick up from where we left off during part 1, which was held on December 10, 2023, and continue our focus on that special group of individuals, our adolescents. But why adolescents? Health. One might ask. Adolescence is a period of rapid physical, mental, emotional, and psychological changes. It can be overwhelming for these individuals during that phase of their life. It is also an important period between childhood and adulthood and has a profound effect on the physical, mental, emotional, and psychological health of the broader society. In Jamaica, vaccination has proven to be an effective way of preventing or attenuating severe illness such as tuberculosis, measles, rubella, and polio, just to name a few. Whereas these have been used in infectious diseases, we are also aware that some vaccines are useful in preventing malignancy, especially in our adolescent population. Vaccination has become more topical in recent times due in part to the advent of COVID-19. While it is necessary to keep abreast of the current trends surrounding vaccination, it is also important to tackle the controversy around the topic of vaccination and vaccine hesitancy. When we think of cancers, we do not routinely think of young adolescent persons. Consequently, in rare cases where there are malignancies in young persons, they may oftentimes be missed and discovered late. Polycystic ovarian syndrome is a condition in which the ovaries produce an abnormal amount of androgens that are usually present in women in small amounts. Its name is derived from the numerous small cysts that are present in the ovaries. Some of the symptoms associated with polycystic ovarian syndrome can be distressing to the female and even worse to the adolescent experiencing those symptoms. Some of these adolescents may present with irregular periods. Polycystic ovarian syndrome is very common, and up to 15% of women of reproductive age have PCOS. This evening, the college is pleased to once again bring to the fore some of the problems that confront our adolescent population and will explore some of these health issues. As such, we have a lineup of presentations to be delivered by distinguished presenters to address some of the problems of our adolescent populations. Doctors Julia Rowe Porter, Christopher Daley, and Leo Walker. We welcome them all wholeheartedly. A special welcome to our members and all attendees who have sacrificed their Thursday evening to attend this webinar. We are immensely grateful. An event such as this could not occur without the invaluable support of our sponsors, administrators, IT support personnel, and board members who selflessly continue to give of their time, advice, and knowledge to bring this webinar to fruition. On behalf of the college, I thank and welcome you all, and I invite you to sit back and enjoy the presentations. Thank you, and God's richest blessings.
Thank you, Dr. Onanujo. All right, I'd like to present to you our first speaker, the lovely Dr. Julia Rowe Porter. She's a graduate of the University of the West Indies, Mona, where she attained a Bachelor of Medicine and Surgery degree and a Master of Public Health degree with distinction. She was employed to the Northeast Regional Health Authority for 10 years, where she served at the Anatomy Hospital and St. Mary Health Department as a District Medical Officer, Deputy Medical Officer of Health, Parish and Regional Non-Communicable Disease Program Coordinator, and, not to say the least, a trainer for various public health programs. She's been employed to the Ministry of Health and Wellness from 2015. She has served as a Program Development Officer with responsibility for immunization and child health. She's also served as the Medical Epidemiologist in the Non-Communicable Disease and Injury Prevention Unit and is currently the Acting Director of the Family Health Unit. Ladies and gentlemen, I present to you Dr. Julia Rowe Porter.
Hi, good evening, everyone. I want to say a warm welcome from the Ministry of Health and Wellness. We want to thank you for this opportunity to present on this topic, adolescent vaccination. And it is indeed extremely timely at such a time as this because, well, we are grateful for the collaboration we've had with our private doctors or general practitioners throughout the COVID the COVID pandemic, and we are going forward in partnership. So my presentation today will focus, and I'm going to get right into it. It will focus on giving you a history of the program, the immunization program, to set a context. And then we'll look at our immunization schedule, the vaccines that are offered and recommended by the ministry. Then we are going to focus primarily on HPV, human papilloma virus, the conditions associated with it, and the HPV vaccination, which will be the lion's share of this presentation. We know that vaccine hesitancy is a problem, so we'll look at just a few approaches and strategies that we should be using as healthcare workers, and then we end with some key messages. So let us go down memory lane. And one of one of the challenges for the program is that we often forget our history. We forget why we're offering vaccines to the public. And so it's important as healthcare providers that we're grounded in the why and the how. So I want us to, well, many of you may not be able to recall what happened in the early 20th century, in the 1900s to 1940s, where life expectancy was low. It was 38 years, and infant mortality was as high as 100 to 200 deaths per 1,000 live births, which really amounts to 1 to 2 children, babies dying of 10. And the leading causes of death at that time were infectious diseases, including cholera, yellow fever, pneumonia, polio, etc. And you'll notice that many of these are vaccine preventable diseases. So in the 1950s to 60s, we saw frequent outbreaks happening, especially for polio and measles. And of course, the children were the main vulnerable group with a high case fatality of 5 to 12%. So the strategy was really mass vaccination, targeting children under the age of 5. Even if low coverage was attained at that time, it really did still have a significant effect. We saw the introduction of smallpox vaccination, and vaccination has been coupled with other public health interventions to ensure effectiveness, such as improvements in nutrition and sanitation, which reduce the mortality. And at that time, we saw an increase in life expectancy at birth to 53 years, and the infant mortality rate decreased significantly to 49 per 1,000 births. In the 1970s to 80s, we see where we were getting more organized. We targeted schools, and this was very strategic because children were in the main target population. And can you imagine, a school is a community of susceptibles. So if you have outbreaks, if you have one child having the disease, then it can easily spread in an environment like that. So school-based vaccination was a major strategy. And at that time, there's a focus on rubella vaccination because, as you know, girls entering their reproductive years would pass on the virus to their unborn children if they became pregnant and cause congenital rubella syndrome. So the campaigns continued, but the program became more and more organized, and the birth of the expanded program on immunization occurred in 1977 globally, as well as in Jamaica and the English-speaking Caribbean. And we had the promulgation of the immunization regulations as well for Jamaica. And there was no opposition because you can see that vaccine preventable diseases were ravaging our children. It was a major threat, and we had to protect our children and protect the program through regulations. Now, we underwent the epidemiological transition where chronic diseases, non-communicable diseases, became the leading cause of death in Jamaica, and our infant mortality continued to decrease with sustained achievements in the immunization program. So you can see that the program has had significant success over the decades. So we saw the last cases of several vaccine preventable diseases, starting with polio in 1982, locally transmitted measles in 1991, diphtheria in 1995, congenital rubella syndrome in 1998, rubella in 2000, and newborn tetanus in 2001. So it's no wonder many of you have never seen cases of these diseases. So the risk perception has significantly declined. It means that the program has been so successful that we're not seeing these diseases. And just a few more milestones to note in terms of vaccine introduction. So the program was introduced in 1977, as I mentioned, and we would have, in addition to measles and polio, added diphtheria, tetanus, BCG, as well as in the 1990s, we saw where combined vaccines were introduced. So you had your MMR. In 2003, you had the introduction of Hep B and Hib. So with time, you see that new vaccines are being developed and added to the schedule. And in 2017, you saw the introduction of the HPV vaccine. And Jamaica was certified as measles, rubella, CRS free globally in 2011. So this is Jamaica's immunization schedule. And I want to just point out that generally most vaccines, and not just in Jamaica, globally, most vaccines are introduced in the childhood period. I want to highlight that for DT, diphtheria, tetanus, there is a third booster or a sixth dose that is recommended for children ages 11 to 12 and adults as necessary if they haven't gotten the full 6 doses. So previously 5 doses were given, and then there was a recommendation to revaccinate every 10 years or boost every 10 years. But if persons get that full 6 dose schedule, then there's really no need for the 10-year boosting. We see that hepatitis B birth dose was introduced. I'm just pointing out some new features of the schedule that you may or may not be aware of. So a birth dose of hepatitis B was introduced last year, January, which is given in a hospital, in addition to the 3 doses of hepatitis B. And we still continue to vaccinate adults. I want you to note that since Hep B was introduced in 2003, then our adolescents would be vaccinated, because that cohort that just started would be about 20 years old now. So all of them should be fully vaccinated, but it's important that you check their status. They really ought to have all their doses by adolescents. You would know that MMR is 2 doses, second dose is 18 months and not 46 years. It's important that they get that second dose before they reach the age of 2. And then you'll know that for HPV, we give it in adolescents. So that's the only one on the schedule here that is introduced in the pre-adolescent, adolescent years. And we'll get more into the schedule. And I'm just showing you here the schedule by age. So the birth doses of BCG and hepatitis B, and those are given in hospital. Then you have 6 antigens given at 6 weeks, 3 months, and 6 months of age. At 12 months, you have the MMR first dose, and then at 18 months, DPT polio, first boosters, as well as a second MMR. 4 to 6 years is the DPT and polio, and then at 11 to 12, we have those that are entering high school, they get their third booster and HPV. So let's get right into human papillomavirus. So we all know, these are reminders that HPV is the commonest viral infection in the reproductive tract, and it is transmitted by sexual contact. It is responsible for several conditions, in particular cancer, cervical chief among them, as well as other anogenital cancers, vaginal, penile, vulvar, and it also is responsible for mouth and throat cancers and other head and neck cancers. There are over 200 types, and of note, there are high-risk types of focus, and the 2 high-risk types that contribute to most morbidity and mortality are type 6 and 18, which cause over 70%, the vast majority of all cervical cancers. And of note, HPV is essentially responsible for all cervical cancers, but 16 and 18 are responsible for the lion's share of them. They're also responsible for 85% of HPV-related head and neck cancers and 87% of all anal cancers. And of note, there is a long incubation period for HPV. Most persons will clear the virus once they get infected. However, it takes 10 years for the virus to progress to invasive, precancer and invasive cancer. So there is a window period for early detection. This data is a little outdated, but in 2012, we noted that there are just about 400 cases of cervical cancer diagnosed annually, and persons may say, well, that's not a lot, but then there's a significant ripple effect in terms of the cost, and there's data which I'll show you on the profile of these women. These are not elderly women, these are women in their productive years, mothers, sisters, wives. So it has a significant effect on society. It is cervical cancer is the third leading cause of female cancer. And local data shows that over just about 54% of a sample in Jamaica were found to have HPV infection, among them, the highest among them being single women and adolescents 16 to 19 years, as well as women that had more than 3 sexual partners in their lifetime. And cancer-causing HPV types were found in over a third of women, with HPV type 16 being commonest among them. And this is served as a justification that introducing HPV vaccine is feasible for Jamaica, given our prevalence profile. And note that when abnormal pap smears were tested, over about 71% of those samples showed HPV types 16 and 18. This is data from Globacon, which shows that the age standardized incidence and mortality of cervical cancer is relatively high. So for incidence, it ranks about 4th, rivaling uterine cancer. And for mortality, it ranks 3rd, and it's following closely behind colorectal cancer. And this data that I'm showing you here is the eye-opener for Jamaica. Cervical cancer is a major public health threat. So the bar graph on the left is showing the mortality and morbidity, the mortality and the incidence of cancer of countries in the region of the Americas. And you can see that Jamaica is on top. The countries are ranked by mortality, which is the blue bar. And Jamaica is on top in terms of the age standardized mortality. And it still ranks, Jamaica ranks very high for incidence. Bolivia, Guyana, Paraguay have higher rates, so we're just about 4th in terms of our incidence. And the line graph on the right is comparing Jamaica to the Caribbean and the world, and essentially it is looking at the mortality rates by age. And you can see that this is not an old woman cancer. This is affecting women in their 20s, 30s, 40s, 50s. Jamaica is the blue line, and you can see that our rates are significantly higher than those for the Caribbean and the world. So we are very concerned about this condition in women in their most productive years of life. So cervical cancer prevention is a must. But we look on the spectrum of prevention, we're reminded that there's primary, secondary, and tertiary prevention. Primary prevention is preventing the condition from happening at all. And that is through HPV vaccination and education. So vaccination must be coupled with, avoid smoking, safe sex, condom use, one partner, etc. Right? And you can see the graph at the bottom showing where to apply these preventive strategies. So primary prevention will occur starting age 9, so early adolescence, to prevent the infection. Secondary prevention is really cervical cancer screening, early detection and treatment, so that we can prevent morbidity and mortality. And then tertiary prevention is treatment of the cancer once it is diagnosed. There is a global strategy to accelerate or elimination of cervical cancer. So it can be eliminated, and countries like Australia, Scotland, Canada, I believe, are well on their way to eliminating cervical cancer. Cervical cancer is actually rare in those countries. And the global strategy has a target to achieve a mortality of 30% reduction in mortality from cervical cancer. And elimination is achieved when there are less than 4 cases per 100,000 woman years. And we need to achieve 3 targets. So prevention in terms of HPV vaccination, we need to achieve 90% of girls fully vaccinated with HPV by the age of 15. 70% of women screened with a high precision test at ages 35 and 45 years, and 90% of women identified with cervical disease receiving treatment and care. So this is really showing introduction of HPV vaccine across the Americas over the years. So people keep saying it's a new vaccine, but it's really not new. The first country to introduce it on this side of the world, in the region of the Americas, is actually the USA. This was in 2006. So you can see since then, there has been a gradual increase in the number of countries introducing the vaccine. Jamaica would have been in 2017. And at this point, over about 90% of girls, when you look at the population across the region of the Americas, 92% of girls are now living in countries where the vaccine has been introduced, which really is, 47 of the 52 countries and territories on this side of the world. Most countries are using the quadrivalent vaccine, and 57% of countries, or 26 countries, include boys in their schedule, and the rest girls only. This is showing just a list of all the countries that have introduced the vaccine to date. I had mentioned the US was 2006, the latest country, Nicaragua, last year. The map is showing Cuba, Haiti, Venezuela that have not introduced, and I believe there are 4 countries in all that have not yet introduced the vaccine. Jamaica was 2017. This graph is showing what our coverage achievements have been in terms of first dose measured in 2020. And you know that the target, as I mentioned, was 90% coverage. And globally, the mean coverage achieved was 45. So globally, we're not there. But then the data was stratified by income status of country. And you'll notice that there is a disparity where in high income countries, their mean HPV coverage for the first dose is 57%, compared with upper and middle income and lower income countries, to low income countries. They have achieved 36 and 38 respectively. So you can see that the higher income countries are achieving higher doses, a higher coverage, but the majority of the cases, I believe over 80% of cases of cervical cancer are in the lower income countries. So that's a concern of inequity that needs to be addressed. So we know that the vaccine prevents infection from specific types of HPV, and it prevents cervical and other HPV-related cancers. And we know how vaccines work. They stimulate the immune system to produce antibodies against a specific germ to protect the body from that disease if it becomes exposed. There are 3 types of vaccines. There's a bivalent, quadrivalent, and nonavalent. Bi meaning 2, covering for 2 types, quad 4 types, and nona 9 types. All 3 vaccine types protects against types 16 and 18. And this diagram is really illustrating that, where the bivalent covers just the oncogenic high-risk types that are most concern, 16 and 18. quadrivalent has 2 more, which has 2 low-risk types, 6 and 11, which protects against genital warts. And the 9-valent vaccine adds 5 more oncogenic types, but note that this may seem, you're getting, this is the most effective one, but the effectiveness of the quadrivalent and the nonavalent are pretty similar, because remember that 16 and 18 cause the vast majority of cancers. The nonavalent is particularly expensive, so there is concern that you're not getting value for money if you do widespread introduction of the nonavalent. So introduction of the quadrivalent and the bivalent are enough and effective to control cancer. When Jamaica introduced the vaccine in 2017, there were concerns about the supply globally. There were few manufacturers that produced HPV vaccines, but now there are 6 in all. There are 3 brands of bivalents on the market. Jamaica had started with Cervarix in 2017. It is now licensed for both boys and girls. There are 2 brands for quadrivalent vaccines, including Gardasil, and then there's a Gardasil 9. So we know that the vaccine works best if it is given before exposure, and that's the reason why it's given to them young. It's not a treatment, it's prevention. And that's important. We tend to be treatment focused as physicians, and prevention is key. Note that HPV vaccination does not replace cervical cancer screening, they go hand in hand. There are few contraindications to getting the HPV vaccine, and those include anaphylaxis, so severe allergies that are known against the HPV vaccine. It is not to be given in pregnancy. This is not to say that there are studies showing that there are teratogenic effects. It's just that there's no data, and we are on the side of caution. Note that those that have inadvertently gotten HPV vaccine in pregnancy have not shown any adverse effects, but it is not recommended. You don't need to do a pregnancy test before you give the HPV vaccine. Just ensure that you ask, and once, or if you know that they are pregnant, then you delay the vaccine until after pregnancy. And severe febrile illness is a temporary contraindication. If they have a mild cold, sniffles, that's not a contraindication, they can't get the vaccine. Now we're looking at the schedule in detail, where Jamaica updated our schedule. We introduced it to girls because cervical cancer was the main public health condition of concern that needed to be addressed by the national program. But we have expanded it to boys. So as of last year, April, boys 9 to 14 can get 1 dose. We had also introduced primary just school-based population. So grade 7 was the target, but children starting at 9 can get it, and entering grade 7 is a key milestone because they do the school medicals. So most of them will get it at that time as a strategy, but they can get 1 dose up to the age of 14. 1 dose, which is great, because getting that second dose in has been a challenge to get them back to come back for that second dose. Girls 15 to 26 are offered 2 doses, and persons that are immunocompromised are still offered 3 doses of vaccine. The 2-dose strategy, those 2 doses are given 6 months apart. Why 1 dose? When HPV vaccine was introduced several decades ago, there was a 3-dose vaccine, and then eventually it decreased to 2, and now 1 dose, because we have data that shows that immunogenicity of the vaccine is actually long-lasting, and 1 dose lasts vaccinees into adulthood. And we know that girls who are aging out of that 9 to 14-year window, that is an opportunity lost, because the earlier they get the vaccine, the better. since we have introduced the one-dose strategy, and this is something that is recommended by the World Health Organization, studies have shown and proven this in terms of the effectiveness of giving one dose. It's really better than no vaccine at all. One dose shows effectiveness, and it is also efficient use of resources, especially if they are limited. The impact of giving one dose is similar to the impact of giving 2 doses when you look at outcomes. And even if the data or long-term studies show that, you know, the effectiveness is, you know, just about 80% of the 2-dose vaccination strategy, then it still achieves significant protection for decades into their adulthood, up to 20 to 30 years. And let us say for argument's sake, more data comes in 5 to 10 years to say, okay, 2 dose is really better, then they can still get the second dose of the vaccine data. So 1 dose has been recommended globally, and countries have the option to switch, and we have done so in Jamaica. Now, this data is showing, sorry, 1 second. Sorry about that. I have an adolescent. I have 2. So this data is showing the first dose across countries in the region of the Americas, and I've highlighted Jamaica, where you see the star here, in terms of coverage. These are coverage estimates. So in 2019, this was in the height, this is pre-pandemic, and we were accelerating the program. We had achieved 23% coverage. You can see us against other countries that perhaps introduced the vaccine earlier and had better achievements. So I'm not saying this is great. It's actually not very good, because the required coverage is 90. Not many countries achieve the 90. So it's really saying we do have a far way to go. But because we had introduced a primarily school-based vaccination program, COVID-19 just totally devastated the program. You see, in 2022, we had a coverage of 4. So this year into and beyond, we are reactivating the program and using different strategies, new strategies, additional strategies to ramp up our coverage. This is showing vaccines given data since we introduced the vaccine in 2017. October would have been the latter part of the year, so we would have just done a few doses, less than 3,000 first doses. But look at 2018 and 2019, we were scaling up with time and with intensified public awareness, especially in 2019. Where we gave over 13,000 doses. And then you see 2020, 2021, program was entirely devastated. And then recovery started in 2022 into 2023, and we're hoping that we can reach 20,000 doses at least in this year. Now, this is showing one main point where the World Health Organization published a list of 10 threats to global health. And these include concerns like air pollution, NCDs, microbial resistance, antimicrobial resistance, you know. In that list is vaccine hesitancy. And I want you to know that this is not threats to the vaccination program. This is threats to global health. What is vaccine hesitancy? It's the reluctance or refusal to vaccinate despite the availability of vaccines. And this threatens to reverse progress made in tackling vaccine-preventable diseases. So remember the history where we eliminated several diseases that protected children, millions of lives saved. millions of cases averted through vaccination. And to maintain that achievement, we need to maintain coverage of 95%. But because persons are skeptical about vaccines now, they haven't seen these diseases, the enemy is now the vaccine and not the disease. And there's a lot of misinformation, there are lots of myths that are accessible on social media, which are casting doubts and fears in our population. So this is a major threat that we need to address going forward. Vaccine hesitancy, in terms of our approach to addressing it on an individual level, need us to look at who is refusing. So in the center, and sometimes because the very vocal ones are so loud, we think that everybody is just against vaccination. But oftentimes the vocal ones that are denying it flat out, you won't be able to change their minds, there are fewer than those that are sitting on the fence and just doubtful. So you need to determine who is a denier, where if you attempt to change their mind, you're going to have very low to zero probability of achieving vaccine acceptance. So you put them aside. There are others that you classify as refusers, that they say no, but it really is that they perhaps need more information. There's probably a barrier. Perhaps they had a relative where some adverse event happened and that needs some exploration, interrogation, counseling as well, so that you can win them over in terms of getting a vaccine. And then you have on the outer hesitant individuals, right? Where they'll get it, they'll probably come today for it, and then you don't see them come back for whatever reason. So the vast majority of persons can actually be convinced to accept a vaccine in or interaction with them. In responding to safety concerns, which is the main issue with hesitancy, research has shown that healthcare providers and their interaction and the recommendations and endorsement that they give to parents and patients is highly important. And we are the ones that will provide the reassurance and the endorsement of the vaccine. If we are unsure of the safety and effectiveness of the vaccine, even if it doesn't come out in what we say, or body language and how we deal with a parent that has doubts, will make or break, or will be the decisive factor as to whether or not they take the vaccine. And we need to provide clear responses to questions. Shouldn't beat around the bush. We should be armed with information, ready to address the concerns that they have, and they will have a lot, especially with HPV vaccine. We did a quick rapid assessment, and it showed that generally there is buy-in to protecting children. It's not that parents are irresponsible. They just have a lot of doubts and fears. They have a lot of questions. So we need to be prepared to respond to their questions so that we can convey messages regarding safety and effectiveness. So we need to say in addressing matters of safety that the vaccines are safe. That has to be reinforced time and time again. There are no major safety concerns with the vaccine. It really doesn't have much in it. It really just contains a protein. And the vaccine has been administered to millions of people over the years without serious side effects. Adverse effects can happen, and they're common ones. Like other vaccines, they will get mild local reactions, redness, swelling, tenderness at the injection site, and they get fever as well as vomiting, nausea as well. But it's important for us to say that those go away with time, and if they do have a reaction, they need to come back so that they can be assessed. It's important for us to document these reactions and report them so that we can have our data to report to say, well, in Jamaica, these persons have had a reaction, and on investigation, these have been found to be serious, and so that we can show of the how many doses of vaccines we have given, how many are really serious. And it's important to know that globally, this information is analyzed and investigated in terms of whether or not vaccines are related to anaphylaxis, syncope, mass psychogenic illness, autoimmune diseases, multiple sclerosis, Guillain-Barré thromboembolism. That data is fed on the global level to an advisory committee where that does meta-analysis to determine whether or not there are linkages. And if there are concerns about vaccine safety, vaccines are pulled from the market, have been pulled from the market. None have been found with the HPV vaccine. Fainting may occur. They are adolescents. Babies don't faint, they'll cry. So as we get older and we receive injections, that is something we have to contend with in terms of that fear of the needle. So in adolescents, they may faint, and that's not uncommon. So it's important that they're observed to ensure that we look to see if there are any adverse reactions happening, that they're seated so that they don't get injured if they faint. Winding down, one of the common fears have to do with fertility. So many parents are concerned that their daughters may get infertile or may have difficulty becoming pregnant if they get the vaccine. So there is no evidence that links the HPV vaccine to fertility challenges at all. The studies have been done to do that analysis. And it's important also to note that the enemy is not the vaccine. HPV-related precancers and cancers are the problem. If persons get these conditions, that can put their fertility at risk and not the vaccine. My daughter is too young, so a lot of them will be concerned that we are promoting sexual activity. We're giving them a license to have sex. Oftentimes, I would say, when you go into a car, you put on a seatbelt. Do you put on a seatbelt because you intend to crash? No, it's prevention. It's in the event that you have an unfortunate motor vehicle crash, then you have a seatbelt to prevent the worst. That is what the vaccine is doing. It is not a license to go and have sex or a license to go out and get an STI. And it's important for them to understand that the vaccine works best in persons that are young. Vaccines have a history of a better immune response the younger it is given. And also, it needs to be given before exposure to the virus. And getting the vaccine earlier means that they get the protection earlier before exposure happens. So finally, just a few key messages. Vaccination is the single most cost-effective public health intervention. And the program has had a long history of success, where several millions of deaths across the world have been averted because of vaccination. Efforts really now need to be channeled into life course vaccination. So our children are protected. We need to look at our epidemiological transition. We have viruses that are preventable. We have cancers that are a scourge. Who would not want a vaccine to prevent cancer? Everybody here knows someone that has cancer or has had cancer, treats patients with cancer. This is a low-hanging fruit where you can give a vaccine to prevent cancer. And it is a safe and effective vaccine. It's important to note that we are key in improving the uptake and combating vaccine hesitancy. I want to also use this opportunity to say that we are really taking the approach of using that consultation space. So it is offered free of cost in our public facilities, the HPV vaccine, but we want to partner with private doctors. Many of you may have a relationship with your health departments, and you may get vaccines from your health departments please get the HPV vaccine. Use your space to speak with the parents and give the vaccine. That's how many countries have actually achieved their high coverage rates, where it's offered in a healthcare setting where you have that opportunity to address those myths and fears and doubts. So I want to thank the Pan American Health Organization for providing data on the program. And I want to thank you for your attention and just reinforce the message that HPV vaccination is cancer prevention. Vaccinate get the children vaccinated today. We'll be ramping up our public awareness. That's a major strategy, and we welcome the partnership to promote this important program. Thank you.
All right, thank you, Dr. Julia Porter. I'm just highlighting for you, Dr. Julia, that there are 4 questions in the question and answer section. If you could just have a look at those for me. Some of them you answered in your presentation. All right. And so we will move on to, I see here on my program that it's a sponsor presentation that's next.
Hey, Dr. Bukal. No, we don't have anything from a sponsor at this time. I believe it's our next presenter.
All right, all right, all right. So according to my schedule, the next presenter is Dr. Chris Daley.
Sure, Dr. Daley's here. I'm sure he's ready.
All right. So let me introduce Dr. Christopher Daley, my esteemed classmate, who is also an avid painter. A lot of people don't know that about him. Welcome, Dr. Christopher Daley. Just finding your thing here.
Hello?
Yes, Chris. Not quite yet. Let me formally introduce you.
Okay.
So Dr. Daley obtained his degree, his MBBS, at the University of the West Indies, Mona. Subsequent to that, he did postgraduate training in obstetrics and gynecology and a fellowship in gynecological oncology, during which he completed his clinical observership at the Royal Infirmary of Edinburgh in Scotland. He's also a member of the Caribbean Gynaecological Cancer Society. He's a fellow of the International Society of Gynaecological Cancer, and he's a fellow in the American College of Obstetrics and Gynecology. His dedication is to advancing medical academia through research, presentations, and he is a university lecturer. I welcome Dr. Christopher Daley.
Thank you very much. Hopefully I still can call you Ken.
Of course.
And of course that introduction sounds so much better coming from you. Let me share screen. I believe that's how it is.
Yes, sir.
All right. So let me go into. Okay.
Yep, perfect. Cancer in adolescent females.
So if I'm get this off the screen here, it's blocking. Right. So I'm intentionally taking my own sweet time to start, because I understand and I've been warned that I need to use all of 40 minutes, which definitely would not be necessary in this presentation. So the topic today was with respect to cancer in the adolescent female, but knowing that January is cervical cancer awareness month, I thought it was fitting to try and stretch a bit and speak a little bit about cervical cancer, and especially in the perspective of how it relates to the young. Not quite as common in persons who are less than 20, but there is still room for research, because even in the very small practice, I'm seeing quite a few number of patients in this younger age group. And so the outline will be just quickly to brief or go over quickly the statistics which are already mentioned. From a surgical standpoint, in terms of the pathophysiology of HPV infection, a quick summary of the immunization again, a discussion speaking with respect to this age group would not be complete without emphasizing the role of immunization as it relates to, in particular, the HPV-dependent cancers which occur. And for the purpose of this presentation, we'll be focusing more on cervical cancer. We're also looking at the role of screening. How relevant is screening in a younger age group as versus to those who are older, and the guidelines related surrounding that. And then more fitting to, I suppose, my area of interest and expertise in terms of the management, especially as it relates to the surgical approach in these patients, and the final conclusion with respect to the presentation. And to get this out of the way. Right, so we know the Jamaica Cancer Registry. It was established in 1958 to record the incidence of cancer in Jamaica. However, most of the registry has been predominantly based from diagnoses or cases which have been documented from the Kingston and St. Andrew. I know there are attempts presently underway to expand the registry as well, to be more reflective of the cases nationally. But as far back as 1958 to 1970, where there was a 13-year review, showed the annual incidence of cervical cancer being 33 per 100,000. And not much has changed over the years. The point making that cervical cancer, as it relates to other areas in the world as well, is one of the highest incidence amongst Jamaica compared to everywhere else. When you look at the age-specific incidence of cancer in Kingston St. Andrew, even fast forward into 2003 to 2007, again, among the highest incidence of cancers among women, which we can see as well with respect to breasts and large bowel. And so when they look at the average incidence per 100,000 per age group, just highlighted, I know it's a very busy table. If we're to focus more on the cervical cancer area, the highest incidence would have been seen more so between the 45 to 60 age group, which we know that, realize now that we have been migrating more into the younger age group, and with respect to the young, specifically those in less than 30 years of age. But however, when you consider persons, especially between 20 and 30, as it relates to HPV-dependent disease, and the whole concept of the age of HPV exposure and infection, and the period that is required for pre-malignant changes to occur in terms of intraepithelial neoplasia, it then speaks question as it relates to the pathophysiology related to the development of cancer in the young. And even in relation to the development of cancer as we know it, that most of the interventions as seen by the previous presenter would necessarily therefore be done in persons of the adolescent age group. So just looking at the estimated age standardized incidence in the world, seen sort of organization in 2020 in cervical uterine consideration in all the ages.
Can you what?
Hello? Can you hear me? Right. You can see that the mostly highlighted areas are those in the Caribbean, some areas in South America, and African countries. And the incidence of cervical cancer is the least in the areas that have had a more long-standing application of immunization or vaccination in the population or established over the years. All right, so just looking again, a discussion on this would not be complete by actually emphasizing and reviewing the basic science behind it. So most human papilloma virus infections are harmless, as we know it, and they clear spontaneously. But persistent infection with high-risk human papillomavirus, especially that of the type 16, can cause cancer of the cervix. And so mainly this occurs in 4 main stages. So firstly, there is infection of the metaplastic epithelium at the cervical transformational zone. There is persistence, so there is viral persistence. And for those who progress, there's progression to cervical precancerous changes. And then finally, there is invasion. So this diagram is a simplified schematic representation of the role of HPV in carcinogenesis. So there is HPV integration and activation of the oncogene, in particular, where there's E6 oncoproteins as they bind P53, and the degradation results in the apoptosis inhibitor. So E6 oncoproteins bind to cellular tumor suppressor protein P53, and also primarily E7 protein binds to PRB protein, and the replication of the enzyme gene overexpression leading to cell proliferation. So in a nutshell, we have the immortalization of the cells which occur, and of course, the haphazard, unregulated growth of cells resulting in cancer, especially in this area of the squamous junction, which is particularly vulnerable to the infection. So most HPV infection is cleared within, say, 2 years. And for persistent infection, the transition to intraepithelial neoplasia usually occurs from 5 to 10 years. However, infection to CIN3, which is high-grade changes before it becomes cancerous, can be as short within maybe 5 years and peaking at 30 years. So how does this pathophysiology relate to cancer in the young? I'm reminded also of this article, which was published and which highlighted at the National Women's Hospital in Auckland, New Zealand, where unethically the treatment of high-grade precancerous changes or cervical intraepithelial neoplastic changes 3 was withheld from a substantial number of women between 1965 to 1974 as part of a clinical study led by Dr. Herbert Green at the time, and had become popularly known as the Cartwright Inquiry. The review of the findings, however, gave us some insight as to how quickly or the likelihood of progression to cervical cancer in patients with high-grade changes. And we realized that the cumulative incidence of invasive cancer of the cervix or vaginal wall was approximately 30% versus 0.7% in those with adequate treatment. However, the timeline for CIN3 varies and is mostly uncertain. The role of HPV carcinogenesis in the younger patient requires further studies. So HPV-16 is the greatest risk factor for developing precancerous lesions in the young patient. We see that in a prospective study of type-specific HPV and the risk of cervical neoplasia, HPV-16 was found to be the greatest risk factor, which showed in the 16-year follow-up, the risk of CIN3 with HPV-16 was 14, almost 15% in women less than 30 years of age versus 8.5% in women over 30. So the cumulative probability of having the precancerous lesion is greater, again, with HPV-16 as demonstrated by this curve. Locally, HPV prevalence is highest, was shown in a study of 852 sexually active women, ages between as early as 16 to 49 years. What's highest amongst women between 16 to 19 years. HPV-16 is the most, again, emphasizing most common oncogenic genotype noted in this age group. So primary prevention, as emphasized over and over again, is sexual health education, use of barrier methods and warnings against use of tobacco use, but most importantly, the introduction and strategies which are being put into place in order to help with our national immunization as it relates to HPV vaccination. Won't delve too much into this because it was thoroughly ventilated in the previous presentation, but we see from this a overall contribution of HPV in cases of compared to CIN1 versus CIN2 versus CIN3. In other words, low grade versus high grade changes. And based on the prevalence of these HPV genotypes, we have seen the advent of vaccines such as the Cervarix, which protects against HPV-16 and 18, and also the promotion of other vaccines, which have moved from protection against 4 genotypes to as much as 9. And so the World Health Organization, April 2009, issued a position statement recommending that routine HPV vaccination of females be included in national immunization programs. And so we see the national immunization programs as it relates to the other countries, all countries in the Caribbean and Jamaica, which have been mentioned before, the implementation, hopefully primarily between the ages of 9 and 14 years. And most of us have seen at least even most of us have heard in the news the reports of schools HPV vaccine and initially implemented and garnered with respect to 2 doses as the most effective option. Of course, we've seen the advent of COVID and the momentum of HPV vaccination has been slightly faltered, especially in 2020, but again, is gaining greater momentum as you see. So the WHO in 2019 recommended vaccinating of girls by age 15 years offers the highest level of protection and public health impact on a global scale. And so the strategic, however, advisory group of experts on immunization suggested that a single dose of the vaccine could be used in this young age group and published a recommendation for 1 or 2 doses up to the ages of 20 years. So Jamaica, as we have heard as well, is adapting this principle, but many other countries over the world have used this principle to good effect. The Australian Technical Advisory Group on Immunization announced that it is changing its national immunization program to align with the single doses. The Costa Rican vaccine trial has collaborated and confirmed the effectiveness of single dose, and the International Social Research Council study from India has also validated the effectiveness of the single dose. So of course, single dose versus triple dose increases compliance and decreases the cost, and therefore improves cost effectiveness of the delivery of the vaccine and our goal with respect to decreasing ultimately the incidence of cervical cancer. So we have seen the advent of screening, many strategies of screening, which would be for another presentation with respect to pap smears or HPV or primary screening or co-screening with pap smears and HPV testing. But I'd like to draw your attention to a multi-center prospective study which looked at the effect of cervical screening on the incidence of cervical cancer. And they looked at the odds ratio of cervical cancer in screened versus unscreened women as a function of age. And the odds ratio increased with decreasing age and is greater than 1 for those screened at ages 20 to 22. So in other words, the impact of screening in reducing the risk of cervical cancer is significantly less. So screening at young ages, 20 to 24, has no detectable, however, has not been shown to have any detectable impact on cervical cancer rates at ages at 25 to 29. So at present, screening is not recommended in the adolescent age group. However, consideration for increasing, therefore, for the age of screening from 21, as we know it, to 25, looked at two main issues. One, the length bias. So the length bias speaks of most cases of cervical intraepithelial neoplasia grade 3 or precancerous changes detected will be slow growing and could safely be left for several years. But the rare cases that we see that progress rapidly in the very young will probably be missed anyway. And cervical cancer in the young is missed in spite of our best screening methods. So what would be our approach to the treatment? So generally speaking, treatment would be involved either surgery or chemoradiotherapy. So the combination mainly of radiotherapy as it relates to external beam and brachytherapy with sensitizing chemotherapeutic agents. However, in this age group, the discussion of fertility issues, especially fertility sparing options, is an important part of pre-treatment counseling. So you'd imagine this is especially challenging, that the many modes of treatment which we have available to us now have adverse effects on fertility and also sexual function. So let's look briefly on fertility sparing surgery as we know it. Now, the preoperative assessment, as we know, is clinical staging, which is assisted with MRI of the pelvis and, as mentioned before, counseling. Now, fertility sparing treatment is not indicated in certain types of cervical cancer, such as neuroendocrine carcinomas and non-HPV related adenocarcinomas. It's not recommended if there is suspicion of node involvement and especially confirmation after nodal assessment, if there is positive margins or if the tumor is more than 2 centimeters in size. So the latest modification of the staging from the fetal staging of cancer and cervical cancer can be conveniently divided into those which have early stage and to those which would include those from stage 1 with tumors less than 2 centimeters, highlighted here, and those which have locally advanced disease, which beyond the red box highlighted, and progressing to metastatic disease, which is that of stage 4. So the candidates for fertility sparing is more so with respect to patients who have stage 1 disease with tumors which are less than 2 centimeters. So what are the types of fertility sparing surgery? So one of the simplest type is to just remove a large area of the affected cervix and leaving a tumor-free margin. It's known as a large cone. Another type is that of a simple trachelectomy, or you may approach it vaginal radical trachelectomy, or you may do a abdominal radical trachelectomy or laparoscopic route. So this is just a photo board which shows the uterus here, still attached to the ligament that attaches it to the pelvic sidewall, known as the infundibular pelvic ligament. And this is the cervix, which has been mobilized. So a trachelectomy has been done where the cervix has been amputated, and a circular arch placement is shown in this photo. And this is a specimen which has been removed, showing the cervix, the parametrium, which is a tissue, which is a cushion that surrounds the cervix, and the vaginal segment. So as you know, chemoradiotherapy affects sexual function in many ways. Radiotherapy causes vaginal dryness and the narrowing of the vaginal and shortening of the vaginal canal. It affects ovarian function and fertility, and of course, subsequently affects issues relating and surrounding to body image. So what is it that all of these taken into consideration would bring in the forefront? We need to perhaps review more on the characteristics of the cervical cancer in the very young patient, which do not tie into what we understand and already know with respect to the pathophysiology of HPV infection and the timeline that is gauged towards the progression of this disease. Ideal age for screening, especially in the era of vaccinated women, would need future studies. There need to be also novel approaches for primary prevention of cervical carcinoma in the young as required. And of course, the greater support for expanding of the National Cancer Registry so we can have a better and greater understanding. So that's it. Thank you very much. How do I Excel take this?
All right, thank you very much, Dr. Daley, for that very interesting discussion on cervical cancer. I noticed that most of the questions in the question and answer section are about the vaccine, and they are currently being answered by Dr. Julia Porter Rowe Porter, sorry. All right, so our next presentation is by Dr. Leo Walker. Dr. Walker obtained his Bachelor of Medicine degree at the University of the West Indies, Mona campus. He also obtained his Doctor of Medicine in Obstetrics and Gynecology and a fellowship in maternal fetal medicine from the University of the West Indies. This esteemed doctor is currently one of only a few certified persons in his field to offer the O-shot, and that provides women with vaginal tightening by injecting their own plasma, fresh frozen plasma. And he also is working along other maternal fetal medicine specialists in the maternal fetal medicine unit at the Victoria Jubilee Hospital. He also works in 2 private practices on Westminster Medical Center and Healing Women's Clinic on Hillcrest Avenue. So I present to you now Dr. Leo Walker.
Hi, good afternoon, everyone. Good evening, rather. I'm Dr. Walker, and thank you for inviting me to speak at this conference. Today, I'll be talking briefly about menstrual disorders and PCOS, polycystic ovarian syndrome. Allow me to just start this presentation. Right. Well, just a brief outline. We're going quickly through definition, how we diagnose some of the pathophysiology, as well as the treatment options for menstrual irregularities associated with polycystic ovarian syndrome. Now, polycystic ovarian syndrome is one of the commonest endocrinopathies in women of reproductive age, affecting around 4 to 12% of women. It's a heterogeneous disorder, really of unclear etiology. We haven't really elucidated the exact mechanism by which polycystic ovarian syndrome occurs, but it commonly results in ovulatory dysfunction, menstrual irregularities, as well as androgen excess in women, and is the commonest cause of anovulatory infertility. Now, the classic syndrome was originally described by Stein and Leventhal in 1935 as the association of amenorrhea with polycystic ovaries, hirsutism, and obesity. It's now recognized that polycystic ovarian syndrome represents a disease spectrum characterized by hyperandrogenism, menstrual irregularity, polycystic ovaries, obesity, and insulin resistance. It should be noted, however, that approximately 51% of women with polycystic ovarian syndrome are actually of normal body mass index. Now, polycystic ovarian syndrome, as the name suggests, is a syndrome, not a disease, reflecting multiple potential etiologies with variable clinical expression. Now, because of this clinical heterogeneity, it is sometimes challenging to diagnose. So as a result, there's actually 3 sets of diagnostic criteria that have been developed to identify and diagnose patients with PCOS. We have the National Institute of Health criteria, which was developed in 1990, and it defined a minimal criteria for the diagnosis of polycystic ovarian syndrome. So it consists of menstrual irregularity due to either oligo or anovulation. Oligo ovulation, meaning an individual has a cycle which spans greater than 35 days, and ovulation, so refers to an individual who has at least 3 consecutive missed periods, so 3 consecutive months with no menses. Second criteria is evidence of hyperandrogenism, whether that is clinical, such as hirsutism, which is facial hair in a male pattern distribution, which could be facial hair, hair on the abdomen, hair on chest, acne, or male pattern balding, as well as biochemical evidence of hyperandrogenism, which is simply just elevated serum androgen levels. And of course, the exclusion of other causes of hyperandrogenism and menstrual irregularities, such as congenital adrenal hyperplasia, hyperprolactinemia, and androgen secreting tumors. We then have the more commonly used Rotterdam criteria, which in 2003 had consensus meetings held in Rotterdam. I appreciate that the syndrome encompasses a broader spectrum of signs and symptoms of ovarian dysfunction than those previously defined by diagnostic criteria. So the new criteria encompassed a broader spectrum of phenotypes considered to represent PCOS and required only 2 out of 3 of the following, either olig or anovulation, clinical and or biochemical signs of hyperandrogenism, and polycystic ovaries on ultrasound, which they further divided as multiple, which is usually greater than 12 peripherally placed follicles, which are often sub-centimeters, so less than 10 millimeters or 1 centimeter in size. Now, simply having one ovary, which fits that definition, is sufficient enough for the diagnosis of polycystic ovarian syndrome. So it doesn't have to be both ovaries which are polycystic, but only one ovary, 10 to 12, often greater than 12 follicles which are sub-centimeter in size. Of course, you also have the Androgen Excess and PCOS Society, which addressed the differences between the Rotterdam and NIH criteria in 2006, and they issued an updated report in 2009, which said that once an individual's androgen excess, again, either clinical and or biochemical, ovarian dysfunction, which is either oligoanovulation or polycystic ovaries, as well as now the exclusion of any other causes of androgen excess. So it basically combined both criteria to give an all-encompassing criteria for diagnosis of polycystic ovarian syndrome. Now, the pathophysiology is where things get a little bit more or less certain. Despite being one of the most common endocrinopathies, a comprehensive explanation of the pathophysiology is still pretty lacking. Now, several theories have been proposed to explain the pathogenesis of polycystic ovarian syndrome. The prevailing concept being that PCOS is the result of one of a number of intrinsic ovarian genetic traits that interact with one or more other congenital or environmental factors to cause dysregulation of steroidogenesis. Now, hyperandrogenism is the key feature of polycystic ovarian syndrome, resulting primarily from excess androgen production in the ovaries and to a lesser extent the adrenals. So the ovaries are the primary source of hyperandrogenism. Now, increased circulating androgen levels contribute to the majority of the abnormalities in menstruation and ovulation, the lipid profiles that we see in patients with polycystic ovarian syndrome, as well as the development of hirsutism and acne. Now, the first recognition of association between glucose intolerance and hyperandrogenism was made by Accredted and Thayers in 1921 and was called the diabetes of bearded women, a very archaic terminology. It is now well recognized that there is an association between increased insulin resistance and polycystic ovarian syndrome, a very strong association with the risk of development of diabetes mellitus in women who have polycystic ovarian syndrome. Now, the primary mechanism driving the increased ovarian androgen production in PCOS includes increased luteinizing hormone stimulation resulting from abnormal luteinizing hormone secretory dynamics, and hyperinsulinemia due to insulin resistance, which potentiates the action of luteinizing hormone and is worsened by obesity. Now, luteinizing hormone are one of what we refer to the pituitary gonadotropins, which also includes follicle-stimulating hormone, which is largely responsible for regulating the cycle. Now, the ratios of follicle-stimulating hormone and luteinizing hormone are closely controlled and well-regulated in the body, and any disorders in terms of this particular ratio can result in these menstrual irregularities that we see in polycystic ovarian syndrome. I'll move on to explain a little bit more. Now, the usual gonadotropin milieu in polycystic ovarian syndrome is that you have increased levels of follicle-stimulating hormone, increased levels of luteinizing hormone, low to normal levels of follicle-stimulating hormone, which leads to an increase in your luteinizing hormone to follicle-stimulating hormone ratio, when in reality, it's often the other way around. Follicle-stimulating hormone is usually secreted in higher levels than that of luteinizing hormone. So there's almost a reversal in what we refer to as the FSH to LH ratios. Now, the increase in serum luteinizing hormone levels results from an abnormal secretory dynamics of luteinizing hormone, which is characterized by an increase in the luteinizing hormone pulse frequency. Now, both luteinizing hormone and follicle-stimulating hormone are regulated by gonadotropin-releasing hormone. and how the hypothalamus releases GnRH largely determines whether it's follicle stimulating hormone that's going to be released from the pituitary or luteinizing hormone that's going to be released from the pituitary. GnRH is secreted in what we'll call certain pulse frequencies. And dependent on that pulse frequency, almost like a Morse code, that usually dictates what is secreted in what concentrations from the anterior pituitary. So that pattern presumably reflects a similar increase in the hypothalamic GnRH pulse frequency, which actually favors secretion of LH more than FSH. So high frequency pulses of GnRH from the hypothalamus causes the release of luteinizing hormone versus low frequency pulses, which favors the release of follicle stimulating hormone. But what happens in individuals with polycystic ovarian syndrome is that pulse frequency doesn't follow the usual pattern. The pulse frequency increases, which causes more LH to be secreted as opposed to FSH. And that is one of the contributing factors to this abnormality that we're seeing in patients with polycystic ovarian syndrome. Now, the decrease in FSH levels obviously refers to that, or is as a result of that increased pulse frequency of GnRH, which favors more luteinizing hormone secretion. And of course, there's now negative feedback of chronically elevated estrogen concentrations because more androgens are converted into estrogens in the periphery, or peripheral fat cells, essentially. Now, the relative paucity of follicle stimulating hormone prevents adequate stimulation of aromatase activity within these cells in the ovary, thereby decreasing androgen conversion to potential estrogen estradiol. Increased intrafollicular androgen levels also results in follicular atresia and anovulation, which causes that characteristic polycystic appearance. Now, what this simply means is that these elevated androgen levels usually results in poor maturation of follicles within the ovary. Now, the normal process is quite simple in that follicle stimulating hormone, as the name suggests, stimulates production or further development of follicles in the ovary. One follicle gradually matures at a rate faster than the others and becomes what we refer to as the mature Graafian follicle. This is the follicle which contains the egg, which a woman would ovulate from on a monthly basis. Now, once that follicle gets to a sufficient size, there are circulating androgens which will prevent other smaller follicles from developing. So it's creating an environment where only this one follicle will mature and produce an egg. The problem which arises in patients with polycystic ovarian syndrome is that levels of FSH are relatively low. So there's poor follicular maturation. Instead, there are higher levels of luteinizing hormone. And what that creates, it creates an environment which is rich in androgens. So apart from the fact that there is very low secretion of FSH, there's also high circulating levels of androgens, which creates an environment where follicles cannot mature. And therefore, these follicles remain at the periphery of the ovary, remain relatively small, unable to ovulate, creating that characteristic polycystic appearance. Now, elevated serum androgens are often converted in peripheral fat cells into estrogens, a process known as aromatization. And generally speaking, because a substantial percentage of patients with PCOS are also obese, they have a greater number of adipose cells and therefore greater areas for aromatization to occur, which then leads to further hormonal imbalances. Now, this conversion results in a chronic feedback at the hypothalamus and the pituitary gland, in contrast to normal fluctuations in feedback observed in individuals who have a regular cycle. This unopposed estrogen stimulation as a result of that estrogen excess, secondary to excess aromatization in these peripheral fat cells, causes excess thickening of the lining of the uterus, which may often result in endometrial hyperplasia. So the endometrium becomes excessively thick, and the number of cells in the lining of the uterus become excessively thick. This is the beginnings of the problems that women with polycystic ovarian syndrome often experience when they have these several months of an ovulation and no period, where the uterus or the lining of the uterus becoming excessively thickened. At some point in time, the uterus is going to become so thick that the blood supply to the lining of the uterus can no longer perfuse or maintain that thickened uterus. And as a result, that lining of the uterus becomes ischemic as a result of lack of blood flow, and it is shed, and there is this extremely heavy blood loss. Now, in terms of insulin resistance, up to 35% of women with polycystic ovarian syndrome exhibit impaired glucose tolerance, and 7 to 10% meet the criteria for diagnosis of type 2 diabetes. Conversely, women with type 2 diabetes are actually 6-fold more likely than non-diabetic women of a similar age and weight to have polycystic ovarian syndrome. So there's a very strong correlation, a very strong link between diabetes, polycystic ovarian syndrome, and obesity. Now, increased circulating insulin levels cause or contribute to the hyperandrogenism in women with polycystic ovarian syndrome in two main ways. It further stimulates the ovarian androgen production, and it inhibits the release of sex hormone binding globulin from the liver. Now, sex hormone binding globulin is a very important protein which is produced in the liver, and as the name suggests, it binds to circulating sex hormones. So once there are any sex hormones which are free and unbound, sex hormone binding globulin will capture it, bind to it, and render it inactive. However, any sex hormones which are circulating, which are free or unbound to any protein, are hormonally active. So generally speaking, an increase in sex hormone binding globulin means that the body will bind to any free circulating hormones, prevent them from acting. However, increased insulin levels actually result in a reduction in the hepatic production of sex hormone binding globulin. So there is less sex hormone binding globulin available to bind to those free circulating hormones. So those hormones will be running wild, exerting their effects. And in an individual who has polycystic ovarian syndrome and therefore has these elevated levels of androgens, this is one of the mechanisms by which these androgens can exert even more of an effect and cause those characteristic features of hyperandrogenism. Now, theca cells in the ovary from women with PCOS also exhibit increased sensitivity to insulin compared to those of normal women. And because insulin also potentiates the effect of luteinizing hormone, insulin and luteinizing hormone act synergistically to stimulate androgen production. So you have almost like a perfect storm where you have obesity, this increased adipose tissue, increased luteinizing hormone production, and increased secretion of insulin from the pancreas, all leading to an increased circulating androgen levels, which will often result in those characteristic features of patients, that characteristic phenotype of a significant majority of the women with polycystic ovarian syndrome. Now, I alluded to this earlier in terms of the endometrium, the lining of the uterus in patients with polycystic ovarian syndrome. Several gynecological disorders, including PCOS, are associated with decreased fertility and uterine receptivity. In women with PCOS who are oligo-ovulator or anovulatory, the regulatory role of progesterone is suboptimal or absent, and this results in the constant unopposed effects of estrogen on the endometrium, which may invariably lead to overgrowth on the endometrium, unpredictable bleeding patterns, hyperplasia or increased number of cells in the endometrium, and even puts them at an increased risk of developing cancer or uterine polyps. The majority of women with PCOS, approximately 60 to 85%, will exhibit gross menstrual dysfunction. So women will often complain of going several months with no bleed, and then all of a sudden they have this bleed that's lasting 2, 3 weeks, 4 weeks, simply as a result of this constant and continuous thickening of the lining of the uterus and endometrial hyperplasia. Now, the most common abnormalities are oligomenorrhea, in which a woman will go more than 35 days or more without a period, and of course, amenorrhea, when lack of period would go on for more than 3 consecutive months. Polymenorrhea, which is when we get a period at intervals less than 21 days, are very uncommon, although they can occur, but in less than 2% of individuals. Overwhelming majority of women with polycystic ovarian syndrome would either experience oligo or amenorrhea. Now, the menstrual disturbances classically have a peripubertal onset. So one would often report that these menstrual irregularities start usually around 12 to 13 years of age and gradually persist, or sometimes even worsen. Affected women may actually have a normal or slightly delayed menarche, followed by irregular cycles, and this pattern usually correlates with weight gain. They often report that at first the cycles were completely normal, and then at some point in life they gain some weight, and all of a sudden the menstrual irregularity is starting to occur with much greater frequency. Now, although the mechanism is not fully elucidated, many obese women with PCOS resume more regular cycles after relatively small amounts of weight loss. And it's postulated that with weight loss, and even losing 5 to 10% of the body mass index, you're reducing the amount of adipose tissue and thereby reducing the amount of sites available for peripheral aromatization, meaning conversion of these androgens to estrogens. And therefore, you're somewhat reducing that hormonal imbalance which occurs. Now, hirsutism. Hyperandrogenism is manifested clinically by hirsutism acne, as well as male pattern baldness. And it's simply defined as excess hair in a male distribution. And it's commonly noted in the upper lip, chin, around the nipples, and along the vena alba of the lower abdomen. Chronic anovulation is one of the most common causes of infertility. Of course, for one is not ovulating, then the subfertility is a result. Now, because before any pharmacological intervention is initiated, however, particularly in patients with polycystic ovarian syndrome, it's important to have some form of preconceptional counseling done to emphasize the importance of lifestyle modification. As we alluded to, majority of women with PCOS are at risk of developing diabetes, so that is something that has to be screened for. Lipid metabolism is often affected, so they may also have elevated cholesterol levels. So this presents an opportunity to investigate and screen for these things prior to pursuing pregnancy. So we often want to counsel about weight loss, increased exercise, and of course, reducing or eliminating smoking and reducing alcohol consumption in those individuals who smoke and drink alcohol. Obviously, there is a huge psychological impact for patients with polycystic ovarian syndrome, particularly those that are battling with menstrual irregularities and or infertility. Now, women with PCOS may be more likely to have mood disorders such as depression or anxiety when compared to women of similar body mass indexes without polycystic ovarian syndrome. Depression and or anxiety and eating disorders should be routinely screened for and, if present, obviously assessed. And these patients should be referred to the appropriate personnel. Now let's get a little bit into the treatment options. We spent a whole lot of time talking about, defining polycystic ovarian syndrome, how it occurs, the clinical manifestation. So let's get a little bit into the treatment options. Now, one of the most common treatment options which are used in polycystic ovarian syndrome, predominantly for addressing the menstrual irregularities, but also for addressing things like the hyperandrogenism, such as the acne and hirsutism, are the use of combined oral contraceptives. It's most frequently used, the most frequently used long-term management and recommended as a primary treatment for menstrual disorders. There's insufficient evidence over to determine the most effective combination, meaning which combined oral contraceptive has been found to be the most effective. We're talking about Diane 35, Minigyna, Menstrual, Yaz. Which one is the most effective? We really don't have any evidence to suggest one over the other. So you will often find individuals relying on something like Diane 35, which has both ethinyl estradiol and cyperthrone acetate, which has anti-androgen activity. So it will certainly help a lot with the acne and the hirsutism. We also have the use of progestin-only pills or progestin-containing intrauterine systems, such as the Mirena. Now, this can be used as an alternative for endometrial protection because they are also associated with abnormal bleeding patterns in an overwhelming majority of users. Reason being, particularly for the progestin-only pills, it does require that the individual takes them at around the same time every single day, because if not, there is an increased risk of what we refer to as a withdrawal bleed. The Mirena, however, is particularly useful for individuals who have a thickened endometrium, because that constant supply of progestin will help to thin that endometrium, reduce the risk of these heavy bleeds, but also reduces the risk of endometrial carcinoma and endometrial polyps later on in life. Now, the regime for cyclical oral progestin or progestin-containing intrauterine device that most effectively prevent endometrial cancer in women with PCOS is unknown. So, you know, again, it's a similar question about which progestin-only pill is best used, which progestin-containing intrauterine device is best equipped to reduce this risk. That hasn't been something that has been borne out in data. However, the most commonly used ones are either Provera, northisterone, if we're talking about progestin-only pills, and of course, Mirena, if we're talking about the intrauterine device. What about, you know, those patients who have issues with infertility and are desirous of pregnancy? Well, again, one of the most commonly used ovulation induction agents is clomiphene citrate, otherwise known as Clomid. Now, this has traditionally been the first-line treatment agent for an ovulatory woman. And usually have a 6-month live birth rate ranging from 20 to 40%, depending on the population that is being studied, which is pretty good. 1/2 of all women who are going to conceive using clomiphene will do so in at the 50 milligram starting dose, with around 20% at the 100 dose. So over the majority of women will conceive through the use of that 50 milligram start dose. It's usually 50 milligram daily for 5 days, and often commenced on day 3 to 5 of the cycle. Most women will ovulate within 5 to 12 days after completion of the course. I usually advise women to use ovulation kits so that they can clearly and objectively see when they're ovulating and therefore time intercourse accordingly. Of course, for those who fail to conceive through the use of clomiphene citrate, there's also gonadotropins, which are usually sub-Q or intramuscular injections. Low-dose therapy with gonadotropins actually offer a higher rate of ovulation and monofollicular development than that of clomiphene citrate. And of course, there's a significantly lower risk of ovarian hyperstimulation syndrome. Now, the reason why this is there is that it should be pointed out that in individuals with polycystic ovarian syndrome, these ovulation induction agents have a higher risk of both multifetal pregnancies, as well as a complication of ovulation induction called ovarian hyperstimulation syndrome. So in order to reduce this risk, particularly in individuals with polycystic ovarian syndrome, who are usually deemed as higher responders to gonadotropin therapy, we use much lower doses in these individuals and do what we'll call a step-up regime, meaning we use lower doses, we monitor response to therapy, and we increase doses at very small increments until we get a desired response, thereby reducing the risk of multifetal pregnancies, twins, and reducing risk of developing ovarian hyperstimulation syndrome.
Looking good.
There's also the use of ovarian, which can be either done laparoscopically or, well, most often done laparoscopically, but can also be done via open means or laparotomy. The fertility benefits, however, of ovarian drilling may be temporary, and adjuvant therapy after drilling with clomiphene or gonadotropin may be necessary. Again, metformin, one of the common agents that we see being used for treatment in patients with polycystic ovarian syndrome, again, to combat that relative insensitivity to insulin. Metformin are one of the drugs which are used, which help to increase peripheral sensitivity to insulin, thereby reducing this hyperandrogenic state. Now, its use alone, however, as first-line infertility therapy has not been supported in randomized trials. Most often we see metformin being used in combination with other medications, such as in combination with our combined oral contraceptives, or in combination with clomiphene citrate for those patients who are desirous of pregnancy and we're trying to get pregnant. In terms of hirsutism, as we mentioned, the combined oral contraceptives, particularly Diane-35, which has cypretone acetate, can be used to combat the effects of hirsutism. But there are also other methods that can be used. Now, clinical trials of hirsutism treatment tend to be small, with incomplete assessment of clinical and patient response to treatment. So there is no real primary treatment option for PCOS, for hirsutism in women PCOS, but we do have other well-known options. Again, as I mentioned, the combined oral contraceptives, anti-androgen therapies such as cypretone acetate in isolation or spironolactone. There's eflornithine facial cream, which can be used. And of course, you have adjuvant cosmetic techniques such as waxing, laser therapy, of course, shaving, which is probably one of the more common options, but possibly not the most aesthetically pleasing options, and of course, plucking. Now, are there any pregnancy complications that are notable in patients with polycystic ovarian syndrome? Unfortunately, the answer is yes. The risk of pregnancy complications actually increased in women with polycystic ovarian syndrome. The miscarriage rate is around 20 to 40% higher than that of the baseline general obstetric population. So this is something that we advise all patients with polycystic ovarian syndrome. There's an increased risk of first trimester miscarriages, unfortunately. Moving a little bit deeper and looking more holistically at the patient, all women with PCOS should be assessed for cardiovascular risk, particularly in those individuals who are obese, a history of a sedentary lifestyle, those who smoke, a significant family history of type 2 diabetes, dyslipidemia, and hypertension. These are the individuals who are at particularly high risk of cardiovascular disease. And again, one should always remember that strong association with polycystic ovarian syndrome and diabetes, and vice versa. Of course, there's also the endometrial cancer risk, particularly for those individuals who are not receiving hormonal therapy to combat that endometrial hyperplasia. So patients who have oligoamenorrhea are actually predisposed to endometrial hyperplasia and later carcinoma. It is good practice to induce a withdrawal bleed at least every 3 to 4 months in these individuals. And a thickened endometrium or an endometrial polyp should prompt consideration for an endometrial biopsy and or hysteroscopy, which would offer basically a broader view of the endometrium so we can actually see any suspicious areas and biopsy if necessary. Now, in a prospective study, around 12% of women older than 30 years with polycystic ovarian syndrome actually ended up being diagnosed with type 2 diabetes, compared to only 1.4% of the controls. So any woman with polycystic ovarian syndrome who is overweight, obese, class 1, 2, or 3, should be screened for diabetes, again, because of that strong association between the two. So in summary, polycystic ovarian syndrome is the most common endocrine metabolic disorder in women, most common endocrinopathy of women of childbearing age. It's the commonest cause of anovulatory infertility, and insulin resistance and hyperinsulinemia are pivotal to the pathogenesis of PCOS. Now, treatment often will depend on the patient goals, but often include lifestyle modification, which is weight loss, exercise, a combination of pharmacological treatment for androgen excess, which would often improve patients' menstrual irregularities. I thank you for your time and attention. I'm sorry I couldn't be there to present this live, but if there's any questions, you guys feel free to email and I will respond accordingly. Thank you.
All right. So very grateful for that very detailed presentation by Dr. Leo Walker. And as he mentioned, that was a pre-recorded presentation, and he's open for you to email your questions to him. All right, next up is our question and answer segment. Let me just check the question and answer box. Okay. All right, I see some questions here, and I see that Dr. Arlene Henry Dawkins would like to answer the first question. I'm going to give her the opportunity to do so, which is if a 30-year-old female virgin, if they can receive the HPV vaccine.
Hey, Dr. Bukal, I'm not sure if that might have been a mistake.
Okay.
Perhaps the question is for Dr. Rowe or Dr. Daley.
Right.
Maybe they can shed some light into that. A 30-year-old female virgin receiving the HPV vaccine. Any thoughts on that, Dr. Christopher Daley, Dr. Julia Rowe?
Okay, so I guess I can go first. So two things to note are that the effectiveness of the vaccine, meaning its ability to stimulate the immune system, it is better when it's given at an earlier age. So the older someone gets the vaccine, the less effective it tends to be. And based on data and based on what we have accepted nationally, we go up to 26. So if it's given after that, then there's a risk of not having the best immune response. The person is a virgin, so they would have gotten they would not have been exposed, but you have to be careful about what people call virgins. Suppose that person had oral intercourse, oral sex, right? And I'm just bringing up the point that, remember, you have head and neck cancers. And that's because HPV can be transmitted. It's by contact and not just by sex. So be careful if someone tells you. I mean, it is possible, of course, but I'm just bringing up that point. In terms of for somebody 30 giving it, I know some gynecologists do give it to women that are older. That is really case by case. It's not necessarily gonna be a national guideline to give it at that age. So I would suggest that persons that have cases that they are considering giving it outside of the age range, you speak with a specialist about that particular situation.
Okay, thank you, Dr. Julia Rowe. Dr. Chris, any comments on that question?
Yes, it's always good to follow guidelines. And you have different levels of evidence. And the level of evidence in persons in the older age group would not be as robust as what we know before. It's always a balance between risk versus benefit. I think from a clinician point of view, and I guess from a gynecological point of view, speaking generally, and not necessarily that particular 30-year-old who's a virgin, but older patient, we get that question all the time, 30, 35 years old. Yes, you're going to counsel the patient that even though you're sexually active and there had been evidence, some amount, albeit not as 100% sure that there will be effectiveness up to age 45, I'll be more concerned with respect to screening. So whether or not you've gotten the HPV vaccine, especially if you're already sexually active and you're of that age group, I'll be more concerned clinically with respect to the screening, the yearly examinations, and following up of the patient. And of course, the newer thrust of actually testing for the HPV virus in managing these patients of the older age group, those who are older than 30.
Okay, thank you, Dr. Chris. The next question, is there a national cervical cancer screening guideline and treatment guideline issued by the MOH?
Yes, there is, and I will post the link to it in the chat. It's actually National Screening Guidelines for priority non-communicable diseases in primary healthcare, and it gives screening guidelines for diabetes, hypertension, depression, and 4 of the top cancers, including cervical, prostate, breast, and colorectal. And that's dated 2020. So I'll put the link in the chat. It's on the ministry's website, but you can access it in the link. So I'm finding it now and I'll post it there shortly.
Okay, thank you very much, Dr. Rowe. The other questions have been answered. And if I just direct you to the question and answer section where they have been typed in, the answers have been typed in. Up next on our agenda is the vote of thanks by Dr. Dane Levy. He's the secretary for the Caribbean College of Family Physicians Jamaican chapter. Dr. Levy, I hand over to you.
I am unmuted and I am on video, but my lighting is not so good, so I apologize for that. I just wanted to take this opportunity to say thanks on behalf of the Caribbean College of Family Physicians to all who have participated in this wonderful webinar this evening. I would begin with our moderator, Dr. Kian Bacall, who has ably done her job this evening, ably introduced and monitored and made sure that the program ran smoothly. We, of course, also had prayer by Dr. Arlene Henry Dawkins, yes, and she invoked the Lord's presence for us. And we just want to thank her for that as well, most importantly. Our president, Dr. Seni Onanudo, brought greetings. We thank her as well. That was ably done. And our presenters, starting with Dr. Rowe, followed by Dr. Daley, and then Dr. Walker. All did exceptionally well in their presentations. And I just want to thank them because we need to continue to highlight the need for vaccination, prevention of this dreaded disease, cervical cancer. And of course, we need also to educate our patients and the community at large about this little understood condition called polycystic ovarian syndrome. All 3 presenters did very, very well. And I'm hoping that we would have been stimulated to go forward with what has been presented and the encouragement that we have gotten to educate our patients, to make them more aware of these modalities of treatment and the importance of vaccination. Highlighted was the fact that in some countries, cervical cancer is practically eliminated, and yet it's still such a scourge in our country. So I want to congratulate them all for their presentations. I also want to congratulate our backroom staff headed by Mrs. Lynn Thompson Hyatt and their team. Sam, who oversaw the audiovisual presentation. He, as usual, Allgate Solutions did exceptionally well. No hiccups. and everything ran smoothly. I just want to also thank, well, we didn't have a sponsor, though I did not hear of a named sponsor. So I think I would have covered, everyone was contributed so ably, so efficiently to making this evening's presentation, this evening's webinar, such a wonderful and informative and educational experience. I just want to say that I have personally gained a lot from these presentations, and I've been encouraged to continue to emphasize the need for HPV vaccinations, and also to encourage my other colleagues in the field, to encourage everyone to really double down on being just keeping that focus on these vaccinations, and hopefully the ministry will be will double down as well on their advertisements and their promotion of the vaccines. We know there's such a such a resistance developing to all forms of vaccines. And as Dr. Rowe Porter pointed out, we stand the chance of diseases that were already eliminated coming to the fore again. So once again, thanks to all who were involved in this evening's presentation. I think it was timely. I think their presentations were very, very well researched, well presented, and I think all who were involved deserves a round of applause. And just want to say Godspeed, get home safely, even though you may very well be at home. And thank you so much once again. God bless you all.
Thank you, Dr. Levy. Sam, over to you.
Thank you, Dr. Bukal, Dr. Levy, all our presenters, everyone. Thank you so much. I want to thank Lynn, Thompson, Hyatt, and Suya and Lawrence for all the work that they do that you guys don't see, but I know you know about it because you're calling on the phones and you're sending them emails, as do I as well. Thank you so much for your work. Thanks to the President, Seni Onanuju, and everybody who has made this evening wonderful. Most importantly, thank you to all of you, our attendees, wherever you are, driving, walking, sat at work doing the good work, or at home getting the necessary rest that you need. Thank you so much for looking out for these emails. Thank you so much for continuing to support the Caribbean College of Family Practitioners, Jamaica chapter, and thank you so much for continuing to support Allgate Solutions as well, as we try to bring to you some of these wonderful seminars, webinars, and hybrid events. So, ladies and gentlemen, have a great evening.
Before you go, Sam, I think there's going to be a part 3 of this. Dr. Onanuju, I think we will have a part 3 on adolescent health. We should. We think there were some other topics to cover.
That's amazing. So there you go. Great news. The reward for good work is more work. So adolescent health part 3, we'll look out for that, and I know you guys look out for it as well, and we look forward to your support. Thanks so much, Lynn. Thanks everybody. Have a great evening. Post us in the chat, and it will also pop up on your screens once the app closes or the webinar shuts down, and you'll get an email reminder tomorrow as well. Have a great one, everyone. Stay safe, and see you Sunday for the AGPJ webinar. Look out for that email if you've not seen it as well. Bye-bye.